So, hello everyone. As you see your program and here, this talk was gonna be done by Lídia Mulet Pons. I'm not Lídia Mulet Pons, I'm Mariarca Toscano, and I'm here because she couldn't be here and asked me to present her work, and I'll do my best. I'll try to do it. So her work is about, as she has already presented, subjective cognitive decline and associations with brain integrity, psychological and cognitive factors. So as a little bit of background, we have clear two main concepts: subjective cognitive decline, or SCD, and repetitive negative thinking, or RNT. Subjective cognitive decline is a condition by which an individual will perceive a decline in his or her cognitive ability, but this decline is not evident when we do a neuropsychological assessment. This condition has been shown to be a risk for dementia in these individuals, and it's very important to study this in this case. And if we move forward to repetitive negative thinking, RNT is a style of thinking that maybe some of us here have, in which you keep having self-relevant negative thoughts that are relevant for you, and talks about the future or the past, and encompass cognitive processes such as rumination, worry, and intrusive thoughts. This style of thinking has been shown to be also a dementia risk marker, also a psychological risk marker, and importantly is highly associated with SCD. In fact, is one of the best predictors of SCD, and importantly can be assessed with psychological therapy, so it's a modifiable risk factor of very importance to try to prevent dementia. However, in the literature, there's a lack of studies that include SCD, RNT, and data of neuroimaging and cognition. So our main aim was to investigate the relationship between cognition, RNT, and brain integrity, attending to differences between SCD and non-SCD individuals. To do so, we first characterized these two groups in terms of cognition, RNT, and brain integrity. Then we examined the association between cognition and brain integrity and whether this was different for the two groups. And we also studied the potential influence that RNT have in these two variables, again, paying attention in the difference between these two groups, the SCD and the control group. A little bit of methods. We use data from a healthy cohort that have individuals from middle age to older adults, and in which we found 89 individuals that answered yes to these two statements. In the last 2 or 3 years, my memory has worsened considerably, and I am worried about the state of my memory. Then these 89 individuals were characterized as SCD individuals, and we chose another control group with the same number of individuals but without SCD, and that have same age, sex, and educational level as the SCD group. Then we studied cognition with the preclinical Alzheimer cognitive composite, a measure that is sensible to preclinical cognitive decline that include dementia screening, episodic memory, processing speed, and category fluency test. We studied RNT with the Penn State Worry Questionnaire that include scores of intrusive thoughts, persistent worry, and rumination. And lastly, we studied brain integrity with magnetic resonance imaging. Particularly, we used T1 and T2 weighted images to basically subtract cortical thickness and white matter lesion volumes. With all this data, we use generalized linear models adjusting by demographics such as sex, age, and educational level to test our hypothesis and to reach our goals in the previous slide. So I go to the results. For the group characterization, we show that SCD participants had higher rates of RNT, as it was expected. Also, a tendency towards lower cognition, the same white matter lesion burden, and a thinner right temporal cortex. This area, importantly, is associated with SED in the literature, and also is one of the first areas that starts the atrophia in dementia. For the brain correlates of cognition, we show a tendency to have poorer cognition when there are more white matter lesions. So more white matter lesions, less cognition, but only for the SED group. Regarding cortical thickness, we saw a thinner cortex in clusters of the DMN, the salience network, and also the bilateral parietal areas that were characterized by a positive association between cognition and cortical thickness, but only in the SED group, meaning that those with thinner cortex in these areas and that are SED will have also poorer cognition. But these results in post-hoc analysis were only maintained for the right temporal area. And the take-home message would be that cognition was predicted by cortical thickness and white matter lesions only for SED participants, and one could hypothesize that this is because SED individuals rely more in their structure to sustain cognition than those that are not SED. Then, lastly, for the brain correlates of RNT, we saw no association between RNT and cognition in none of the two groups. We saw higher RNT scores in the SED group associated with greater volumes of white matter lesions. And lastly, again, in the SED group, we saw that those with higher RNT also have a greater cortex in the supramarginal, right supramarginal gyrus, which in the literature has been shown, this area has been shown to have greater cortex in psychiatric cohorts, and also in sustaining cognitive processes such as those underlying rumination, worry, and intrusive thoughts. So SED individuals, we have an overload in these cognitive processes that need for a greater thickness in this area. So the take-home message would be that RNT is related to brain integrity, but again, only in the SED group. So I would like to thank you all for your attention, and my group, those that are in this picture and those that are not here. And well, this is part of a study that has been already published. So I'll encourage you to check this out. And you have here the QR code. And I try to answer, if there's time, any question. If not, you can contact Dr. Mulet Pons or reach us out in the poster session. That she will be back now. She will be here with me, for sure. Thank you.
Sorry. We have time for a very quick question from the audience. Do you want a mic, please? 2 quick questions.
Yes, I was curious to know about what is the interpretation or the hypothesis about the mechanism that links actually this rumination and worry and the cognitive deficits.
Okay, so RNT is a transdiagnostic style of thinking or psychological factor that is associated with stress perception, stress processing, anxiety, depression. So I would hypothesize that this type of thinking would affect the hormonal response to stress, and it has been shown that having higher rates of stress affect the hypothalamic, I don't know if you know, but the axis that is giving cortisol to all our bodies. So if you keep in this style of thinking, you may have higher levels of stress, and that affect in your body, not only in the brain, because the cortisol affects the immune system. Well, I don't know if I'm answering your question, but
Yes,
there are many mechanisms underlying the stress and it's associated with this. Yes.
Okay, so let's go to the second flash talk, just in case, because we spent some time. Thank you very much. Okay. Very interesting talk. Okay. So now we have Mariarca Ascione, yeah? And she will present the modification of attention bias through visual reality and eye tracking for improving anorexia nervosa treatment, a randomized clinical trial.
Hello to everybody. I am a PhD student at Virtual Reality and Psychology lab in the Barcelona University. Today I will present you a new tool that we developed to reduce a specific cognitive bias that anorexia nervosa patients have in order to improve their treatment. Anorexia nervosa is one of the most severe eating disorders with the higher mortality rates. It's characterized by a significantly low body weight, body image disturbances, and an extreme fear of gaining weight. The main object of the treatment of anorexia nervosa is the recovery of a healthy weight that is impeded by this fear of gaining weight. In psychology, the fear of gaining weight is like a phobia, so should be treated with exposure therapy. But in vivo exposure therapy is not the best choice to treat fear of gaining weight, that is an abstract concept. So to overcome the limitation of in vivo exposure therapy, we can use virtual reality. Virtual reality allows for a mirror exposure therapy, body exposure therapy, where the patient can experience the illusion to have a virtual body that, session by session, little by little, increase in the weight until reaching a healthy body mass index in the last session. In our last clinical trial, we found out that this kind of intervention with mirror exposure therapy, with the increments of BMI, can improve not only all the body-related emotion and cognition present in anorexia nervosa, but also the fear of gaining weight. However, we found out that in this study, the patient with the worst outcome were the one that present a specific cognitive bias, the attentional bias. Attentional bias is when I focus exclusively just on some specific stimuli. In the case of anorexia nervosa, the patient have an attentional bias for specific body parts. The most part of the patient focus on the weight-related body parts, so the yellow one. In this case, we have a focalization on the body part they consider unattractive, and this is related with the higher level of body dissatisfaction. But also, they can focus on the blue ones, so the non-weight-related body part. So in this case, we have an avoidance of the body part they consider unattractive. This kind of attentional behavior can interfere with the effectiveness of mirror exposure therapy. Because during the mirror exposure therapy, the patient should look at the whole body. So in the case the patient is just focusing on some specific body part, this is interfering with the habituation response of the mirror exposure therapy, and so with the decrease of the anxiety and fear response. So in this clinical trial, in this project, we wanted to incorporate a training to reduce the attentional bias before the mirror exposure therapy. The attentional bias modification training is based on an eye tracking device into the head-mounted displays of the virtual reality glasses. We asked the patient to look at these different geometric figures that appeared on the body So half of the figures appeared on weight-related body area, the other half on non-weight-related body area, to make the patient learning to have an attention to the whole body parts. So have an equilibrated, balanced focus on the body. So by introducing a prior modification of the attentional bias before the mirror exposure therapy, we expected that the patient have a more balanced attention to the body in order to enhance the effect of mirror exposure therapy. So 75 adolescent female with anorexia nervosa from 14 to 17 years old were allocated in 3 different groups, a control group that just received the treatment as usual, cognitive behavioral therapy, a second control group that received 5 sessions of virtual reality-based mirror exposure therapy with the increment of body mass index, and the experimental group that received in each session before the MET, also the attentional bias modification training. So we expected that the experimental group had better results than the 2 control groups. Each patient had a personalized avatar with the same height, same silhouette of the real body, same color of the skin, same color of the clothes. In the groups with virtual reality intervention, the patients were immersed in the virtual environment, received a full body ownership illusion that helped the patient to feel the virtual body as the real body. Then only the experimental group had an attentional bias modification training, followed by the mirror exposure therapy. In both interventions, we did this increment of the body mass index only if in the last session the level of anxiety were really, really low. So what we found out? The anxiety levels of the patient reduced significantly in both groups with virtual reality intervention. Body dissatisfaction decreased in a significant way only for the control group with virtual reality, even if the experimental groups also tended to have improvements. Body appreciation and body mass index improved for all 3 groups, even if for the body appreciation, the experimental group had the greatest increase. We didn't have any other effect for drive for thinness, body distortion, body anxiety, and fear of gaining weight, even if the groups with the virtual reality intervention tended to have greater improvements. So the overall effectiveness of the mirror exposure therapy was not significantly enhanced by the ABMT. So we did some exploratory analysis to understand what was going on in the experimental group. And we found out that the patient that at baseline, so before the intervention, showed a non-weight related body areas attentional bias, so avoiding the part they consider unattractive, showed a higher reduction in fear of gaining weight. So probably these groups of patients could benefit more from the ABMT. Today we are doing the same study with the early onset anorexia nervosa patients, so with really, really young patients from 0 to 14 years old. So in conclusion, the mirror exposure therapy with virtual reality is sure a tool for treating anorexia nervosa, particularly to reduce anxiety, body satisfaction. And the ABMT, even if did not bring a significant overall effect, may have potential for patients with specific attentional bias profiles, such as non-weight related attentional bias. So to conclude, the use of this personalized virtual avatar and the eye tracking technology show big promise for both research and clinical practice in the treatment of anorexia nervosa. Thank you.
We have time for one quick question.
Hi, thank you. Very interesting talk. It's a quick question. I'm wondering about the time frame when you say pre-treatment and post-treatment? And if you looked into any long-term effects that this could have, and if not, what your predictions would be?
The study lasts 8 weeks. So we did a pre-assessment session, then 5 sessions, 1 a week, then also a post-assessment session. And now we are in the follow-up times. So we did a follow-up after 6 months from the last session.
Any more questions? So thank you very much for this nice talk. So next speaker is Florencia Forte. Hello. And she will be talking about from genetics to psychosocial functioning, unraveling the mediating roles of cognitive reserve, cognition, and negative symptoms in first episode psychosis.
Indeed. Hello, everyone. I'm Florencia Forte. I'm a predoctoral psychologist from the Bipolar and Depressive Disorders Unit here at Hospital Clinic from Barcelona, and I'm here to share with you some results from this work. I have less than 10 minutes to explain a 6-month work. I'll do my best. So, we know that functional impairment is like a core feature of almost all of our patients after a first episode of psychosis, and there are some factors that could influence this functional impairment. So we're going to start with genetics, particularly with polygenic risk scores. They aggregate the effects of numerous genetic variants across the human genome into a single score that predicts an individual genetic predisposition to specific phenotypes or traits or even psychopathological aspects. And today I would like to share you the concept of PRS for educational attainment. It reflects the completed years of school, so somehow it captures associated social, economic, and health outcomes. And in the last years, it has gained a lot of attention in the investigation on first episode of psychosis, because we have seen that higher PRS for educational attainment are related with better cognitive outcomes, with better functioning, and with less psychopathology. Other related concept that impacts on functioning is cognitive reserve, and it refers to brain's ability to resist neuropathological changes, minimize clinical manifestations, and compensate for cognitive deficits. Again, in first episode patients, we have seen that higher cognitive reserve is related with a later age of onset, reduces symptoms, better functioning, and better cognition, or better cognitive performance. And why is cognition important? Because on almost all of our patients, we have seen impairments in verbal memory, in attention, in processing speed, in working memory, executive functions, social cognition, and of course, this impacts in everyday function of our patients. And last but not least, we have negative symptoms, and in first episode patients, they are associated with a poor quality of life, hinder functional recovery, and difficulties adhering to treatment. And these negative symptoms sometimes are like it's a wide concept, are separated in two factors, the factors that are related with diminished expression, the X factors, and those that are related with motivation and pleasure. That's the MAP factor. So keep in mind this, because it's not only interesting but important for the study. So we know that all of these aspects are related, but we wanted to know how they are related, or to get more in deep in this relationship. So we sought to explore the mediating role of cognitive reserve, cognition, and negative symptoms in the relationship between PRS for educational attainment and psychosocial functioning in first episode patients at 1-year follow-up, and to investigate the role of these two types of negative symptoms, the X and the MAP. So how did we do it? With data from a sample that calls the PEPS study, that is naturalistic, multicenter, and longitudinal study. And for this study in particular, we assessed 138 patients that met this inclusion criteria and, of course, did not meet the exclusion criteria. And we assessed them at 3 time points. At the entry, we assessed genetics. At 2 months, to ensure that they are stable, we assess cognition, psychopathology, and cognitive reserve. And at 1-year follow-up, we assess functioning. I'm not going to go too in deep with the instruments that we use. We can talk it later at the coffee break. But we did mediation analysis to test whether the effect of the causal variable, in this case, the PRS for educational attainment, on an outcome variable, in this case, functioning 1-year follow-up, is affected by one or more mediator variables, cognitive reserve, cognition, and negative symptom, both at a whole and at the 2 factors. So we did a serial mediation model that hypothesized a causal chain linking the 3 mediators, but in a specified order and direction flow. So let's go to the interesting part. The results among all of the 7 possible pathways that, that could reach us with that model. The only one that reached significance is this one that we see here. So the gray lines, or the one that it's seguida, the gray line, yes, large, represent the path with significant indirect effects. So we can see that cognitive reserve, cognition, and negative symptoms in this flow mediates the relationship between PRS for educational attainment and functioning. So just to explain, higher PRS for educational attainment affects cognition, cognitive reserve, which affects cognition, negative symptoms, and functioning. So this is like the journal model, but we thought, okay, and if we divide it into these 2 factors that we were talking about of negative symptoms, okay, so we did it. And we saw that the only model that reached significance was the first one, the one that took into account the EXP, the negative symptoms related with expressivity. So again, PRS are related to functioning, but using the pathway cognitive reserve, cognition, and negative symptoms, the EXP negative symptoms. Because if we take a look, even though there are some significant associations in the motivation and pleasure model, we can see that cognition did not affect the MAP significantly, even though the MAP affect functioning, but not using the path that takes into account cognition. So, of course, the most interesting result is the causal chain that we saw from PRS to cognitive reserve to cognition to negative symptoms and functioning. But we're going to go like step by step. So the first conclusion or take-home messages is that PRS has emerged as a promising venue for investigating the genetic basis of cognitive reserve. And this goes in line with literature. We know that cognitive reserve involves like an interplay of genetic and socio-environmental factors. And we know that cognitive reserve has a protective role, both in early and in chronic stages of the pathology. Finally, I think this is one of my favorite results, is that EXP and MAP, those factors from negative symptoms, are differently related to cognition, whereas EXP factors show a significant association, but the MAP not. And why I think it's interesting, because as a clinical psychologist, I think that this has implications for clinical practice, because it takes us closer to the so-called precision psychiatry. And why? Because if we have in mind like these 2 models, we could hypothesize that diminished expression negative symptoms could be improved by interventions that improve cognition. So they could potentially reduce negative symptoms and impact functioning. And on the other hand, the motivation and pleasure model, we know that these negative symptoms impact directly in functional outcomes, but with less influence of cognitive aspects. So we should target engagement rather than solely focusing on cognitive aspects. And finally, we saw robust associations between negative symptoms and daily functioning, which again, it's in line with investigations. So I think that's all I wanted to share with you. Thank you very much for your attention. Thank you to my team, and moltes gracias.
Okay, quick question, one quick question here in the front, please.
Thank you for your talk and interesting talk. I'm in the schizophrenia unit, and we also work with PRS and methylation profile score. And with these results, and I like it a lot, but I wish, or I guess, to know why have you used just the PRS score for educational attainment instead of other, for example, IQ or another PRS also test these samples?
So I have like 2 answers for that. I'm going to go here. So there's, I think that, well, it's okay. So we base our study in a study by, the first one, by Kloger and Segura, which they have already described that cognitive reserve and negative symptoms mediated the relationship between PRS for educational attainment and functioning. So PRS for educational attainment, we already have like a guess that was related to cognitive reserve. But then we, like a next step, and related with my PhD, we said, okay, PRS for educational attainment, but there are others that may be related to cognitive reserve. For example, IQ, or for example, there is a PRS for occupational attainment. And we analyze which one impacts more or is more related with the concept of cognitive reserve. And again, it's PRS for educational attainment. So I guess that is because the IQ PRS only takes into account like the intelligence factor, while the PRS for educational attainment takes into account like other aspects like cultural aspects or familiar aspects or more supportive aspects that only the IQ. And it goes more in line with the concept of cognitive reserve. And the occupational aspect, I think that is because it's quite a young population. I mean, 17, 18 years old, mostly they don't work. So I think that's it.
Okay, so we have to finish this session. I would like to thank all the speakers, all the participants, all the students, and the predocs, the postdocs, and all the questions. Thank you very much. So, 1 second.